Vanakkam. I have now come to know that the patient has an ulnar nerve palsy because he has got certain disabilities of the hand, and on examination I am able to see most of the signs and tests that have been described for a patient with an ulnar nerve palsy. However, before I make a decision about what management is to be done, it would be great if I could just visualize how the nerve appears inside the hand before I actually open it up and see it. I also know that even if I am able to visualize a completely intact nerve, it may still not be functional in certain situations, as it may not be conducting the nerve impulses due to some inherent problems like demyelination. So it would also be good if I could note how much of the nerve is actually conducting the nerve impulses. Only if I am able to see these two, that is, if I am able to image the nerve beforehand, and if I am able to see the physiological function of the nerve fiber, I will be able to make a correct decision about the management protocol. The investigations in a patient with an ulnar nerve palsy are of mainly two types. The first is imaging studies and the second is electrophysiological studies. Before we go further, if you need more information about the basics of electrophysiological studies, the nerve conduction studies and electromyography, I would request my viewers to see the description below this video, which contains the links to see the videos that I have already uploaded on these topics. First, we shall see the imaging studies that can be done. Routine X-rays are useful to identify fracture sites, to identify callus, and to sometimes see bone tumors that can be a cause of compression to the nerve. This example of X-ray showing a supracondylar fracture which has malunited is a classical example of a patient in whom a tardy ulnar nerve palsy develops. The next imaging medium is the ultrasound. Ultrasound, in a case of ulnar nerve injury, will give an assessment of the exact site of the lesion by direct visualization of the involved nerve, which will also help us to know the extent and type of injury, the anatomical details of the nerve, the continuity of the nerve, and any architectural distortion if present, and any other local causes of neuropathy. The advantage of using the ultrasound to image the ulnar nerve are that it can be done quickly, it is cost effective, there are no contraindications, and we get a detailed imaging of the entire length of the nerve. But a high frequency, that is of about 14 Hz linear probe is required, and the nerve can be identified first in cross section, where a honeycomb appearance can be seen, which demarcates it from the surrounding soft tissues. The cross-sectional area of the ulnar nerve must be noted, and for an example, at the level of the cubital tunnel, the maximum cross-sectional area is about 0.065 square centimeters. We need to remember that the nerve is more echogenic to the surrounding muscle and less echogenic when compared to the surrounding tendons. So far, we have seen the description of how a normal nerve appears on ultrasound. We shall now see what are all the changes in the nerve that will denote that it is abnormal. The very first pathological change is the loss of the normal honeycomb structure. This diagram shows a normal honeycomb and how the normal nerve has this particular honeycomb appearance on ultrasound. At the first sign of damage, this honeycomb structure is lost. There will also be a decreased echogenicity, sometimes discontinuity and neuroma formation if the nerve has been totally divided, focal enlargement in some patients, and sometimes surrounding compressive lesions, muscle and soft tissue edema and joint effusions may also be seen. The ultrasound of the ulnar nerve will be useful not only for lesions of the ulnar nerve at the elbow, but also lesions of the ulnar nerve in the region of the wrist. If ultrasound is so useful, how is MRI going to help us? Magnetic resonance imaging adds to the soft tissue details and helps in characterizing the lesion. When studying the MRI, we need to see T1 weighted images, T2 weighted images, and other changes. Please refer to the links given in the description about the video which has described the T1 weighted images and the T2 weighted images in greater detail. In the T1 weighted images, the peripheral rim of fat in the nerve sheath appears hyper-intense while the fascicles appear as hypo-intense dots within. So, the nerve appears as a darker tissue when compared with the surrounding tissues. In the T2 weighted images, on the other hand, it is more important to visualize the denervated muscles which appear hyper-intense 48 hours after nerve injury. If it is a chronic injury, the muscle atrophy will be seen with persistent hyperintensity. Now look at this example of a patient with T1 weighted images of the Guyon's canal and the palm. It shows the three whitish images that we are able to see between the hamate and the pisiform are representative of ganglia that have arisen and are pressing on the branches of the ulnar nerve. There is a change seen in the opponens digitae minimi and the flexor digitae minimi muscle, while the abductor digitae minimi muscle appears to be intact. You can make out the difference between the texture of the involved muscles and the uninvolved muscles, that is the abductor digitae minimi and even the thenar muscles. A transverse section confirms the images of the ganglia and shows clearly the point where the ganglia are pressing on the branches of the ulnar nerve, especially the deep branch. A more distal transverse view at the level of the metacarpals shows the involvement of the intraosseous muscles and the adductor pollicis muscle, which are supplied by the ulnar nerve, while you can very clearly make out the normal architecture of the abductor digitae minimi muscle and the thenar muscles. Other changes like focal enlargement, hyperintensity and altered fascicular patterns are also signs of neuropathy, as seen in this patient where the ulnar nerve shows neuropathy at the level of the elbow. The MRI is a useful imaging tool both in the acute stage and in the chronic stage. In the acute stage, on MR imaging, denervation muscle edema on T2 weighted images is seen 24 to 48 hours after denervation, especially if it is a total axonotmesis or neurotmesis. This change will not be seen if it is a neuropraxia. We should also note that EMG signs of denervation may not demonstrate until 2 to 3 weeks. In the chronic stage, on the other hand, fatty muscle atrophy will be seen after several months as marbled increased intramuscular signal on T1 weighted images. Compressed or entrapped ulnar nerve may itself demonstrate focal enlargement in the chronic stage. We shall now see the usefulness of electrophysiological studies in the investigation of a patient with an ulnar nerve palsy. As you may be aware, the electrophysiological studies consist of study of the nerve, that is, axon degeneration or injury or loss or demyelination as occurs in compression neuropathy or conduction block, and also a study of the muscle by the EMG or the electromyography to study whether the muscle is normal, whether it is denervated completely, and whether the muscle has started getting reinnervated, that is, when the repaired nerve has started growing. Please click on the link shown in the description below this video to see more about the basics of these electrophysiological studies. As far as the ulnar nerve is concerned, there are two main areas where the involvement of the ulnar nerve needs to be investigated thoroughly. One is the elbow and the second is the wrist or the Guyon's canal. In the involvement of the ulnar nerve at the elbow, there are 4 locations where the ulnar nerve may be compressed. It can occur at the medial intermuscular septum, the retroepicondylar groove, the humero-ulnar arcade, or the point of exit from the flexor carpi ulnaris. Of these, the retroepicondylar groove and the humero-ulnar arcade are the most common sites of compression. For the elbow, the nerve conduction study is done with the elbow kept in moderate elbow flexion of about 70 to 90 degrees from the horizontal, and a 10 cm distance across the elbow is measured, and this is done using surface stimulation and recording. When the nerve conduction study is done, the following 4 criteria are analyzed: the nerve conduction velocity, that is the speed of conduction; the nerve latency time, that is the time taken for the impulse to pass from one point to another, and this is sometimes known as DML or distal motor latency, the compound motor action potential created at the muscle that is innervated by the nerve. That is, the amplitude of this CMAP is measured and the configuration of this CMAP is also measured. When a nerve conduction study is done at the elbow, there are certain criteria that indicate that there is an abnormality of the nerve at this level. If there is an absolute motor nerve conduction velocity from the above elbow level to the below elbow level of less than 50 meters per second, it indicates a loss of conduction. Normally, the conduction of the nerve is faster in the below elbow to the wrist segment rather than the above elbow to below elbow segment. This change is about 10 meters per second slower in the elbow segment. If the above elbow to below elbow segment is greater than 10 meters per second slower, it means there is a conduction block again. Similarly, a decrease in the compound motor action potential, negative peak amplitude from the below elbow to the above elbow segment is greater than 20%, it indicates a conduction loss, and a significant change in the CMAP configuration at the above elbow site compared with the below elbow site is also a sign of conduction block across the ulnar nerve at the elbow. The nerve conduction studies of the ulnar nerve across the wrist are also useful. The assessment of conduction to the first dorsal interosseous muscle, in addition to the routine motor latencies to the abductor digitae minimi, is integral to the evaluation of distal ulnar neuropathies at the wrist. When the recording is done at the proximal wrist crease or about 5.5 to 6.5 centimeters proximal to the abductor digitae minimi recording site, the upper limit of normal for the motor latency was 3.4 milliseconds to the abductor digitae minimi and 4.5 milliseconds to the first dorsal interosseous muscle. This means that if the nerve conduction is normal in the ulnar nerve across the wrist, the impulse must reach the abductor digitae minimi in 3.4 milliseconds and should reach the first dorsal interosseous muscle in 4.5 milliseconds. This time difference between the stimulation of the abductor digitae minimi and the first dorsal interosseous muscle will definitely increase with age. So, the comparison should be done with the side-to-side difference from the other normal side. This should not exceed 1 millisecond for the abductor digitae minimi or 1.3 milliseconds for the first dorsal interosseous muscle. Also, a compound motor action potential amplitude less than 6 millivolts for the first dorsal interosseous muscle and less than 5 millivolts for the abductor digitae minimi is considered abnormal. And during the course of this study, if there is a lesion of the deep palmar branch beyond the branches to the hypothenar muscles, there will be a prolongation of the distal motor latency to the first dorsal interosseous muscle in the face of a normal motor latency to the abductor digitae minimi muscle and normal sensory studies. The electromyography should include the abductor digitae minimi muscle and the first dorsal interosseous muscle and the ulnar innervated forearm flexors. If the ulnar innervated muscles are abnormal, the examination should be extended to include the non-ulnar, that is C8 medial cord lower trunk muscles to exclude brachial plexopathy, and the cervical paraspinal muscles should also be examined to exclude radiculopathy. A straightforward case would be when we have a patient with signs of ulnar nerve palsy and evidence of nerve conduction block at the level of the elbow. This would be a very clear scenario pointing to a lesion at the elbow. But it is not always that it is so clear. Let us consider some clinical scenarios for analysis. Let us suppose we come across a scenario where there is only slowing of the nerve conduction velocity across the elbow segment of the ulnar nerve with absolutely no clinical findings. This could most probably be artifactual, either technical error or the effect of cold temperature or it could point to what is known as a subclinical ulnar neuropathy, which definitely needs an observation of the patient over a period of time. A second scenario is when patients present with purely sensory symptoms and the motor studies show normal pattern. How do we interpret such a situation? Such patients usually have a mild or early ulnar nerve involvement at the elbow, and an adequate evaluation may well be done to exclude other pathologies such as brachial plexopathy or cervical radiculopathy and manage patients conservatively. And if we still suspect a lesion that is causing a compression of the ulnar nerve, we need to localize the lesion more confidently by recording the EMG at the first dorsal interosseous muscle, or SSIS, to be recorded. We shall see more about this SSIS as we go along. The third scenario is when a patient has had a surgery on the ulnar nerve, but still patient has presented with persistent or recurrent symptoms. And sometimes there are no pre-operative studies available for comparison. In such a situation, the first step to be done is to rule out other pathological causes like plexopathy or radiculopathy or proximal tumors. The next step would be nerve mapping, that is, we follow the course of the nerve to determine whether or not the transposition was done. It may sometimes establish a kinking due to inadequate distal release. And finally, SSIS, which is short segment incremental studies, can establish whether there is persistent focal compression or fibrosis, which is potentially amenable to reoperation, or whether there has been a devascularization of a long nerve segment which is irreversible. In SSIS, the electrode is slowly moved centimeter by centimeter until a point is reached when there is an appreciable change made out in the motor action potential of the nerve, which denotes that that is the site where there is a lesion. To see an example of this SSIS, which was introduced by McIntosh et al. In 1998, we shall consider the SSIS across the ulnar nerve study at the region of the wrist. The nerve was stimulated at 1 centimeter intervals from 3 centimeters proximal to the distal wrist crease to 4 centimeters distal to the distal wrist crease, with recording the first dorsal interosseous muscle. In this example, in the right palm of the patient, the light yellow area represents hypoesthesia to touch and pinprick, and there is an arrow mark indicative of a positive Tinel sign. An orthodromic ulnar sensory inching test with distal forearm recording at E1 and E2 was conducted at 3 sites: 3 centimeters, 5 centimeters and 7 centimeters distal to the pisiform, noted by the points P3, P5 and P7. And when the recording was studied, you would note that at the level of stimulation at P3, the nerve action potential has a normal configuration, whereas at P5 and P7, the configuration is distorted. This means that the lesion is most probably between P3 and P5 sites that we have chosen, because there is an abnormal conduction delay of about 0.6 milliseconds and definite partial conduction block, almost 81.1% between 3 centimeters and 5 centimeters distal to the pisiform. Let us consider a similar example of an SSIS across the elbow. When the stimulation is at the level of the wrist and the recording is done in the abductor digitae minimi, there is a normal configuration of the action potential. In a regularly done nerve conduction study, the recordings are then done from below the elbow and above the elbow at 10 centimeters and above the elbow at 20 centimeters. We note here that there is an abnormal configuration in all these 3 recordings, and there is a 65% drop in amplitude, 30% drop in the area and 63% prolongation in the duration when the nerve is stimulated below the elbow as compared to stimulation at the wrist. This obviously means that there is some lesion below the elbow that is preventing the signal from reaching the abductor digitae minimi muscle, and we need to find that exact point from where the conduction velocity has started slowing. So an SSIS, as has been described earlier, is done with stimulation 7 centimeters proximal to the wrist, 14 centimeters proximal to the wrist, 23 centimeters proximal to the wrist, 26 centimeters and 29 centimeters proximal to the wrist in the forearm are done, and it is seen on stimulation at 7 centimeters, 14 centimeters, 21 centimeters and at 26 centimeters proximal to the wrist in the forearm, the action potential that develops in the abductor digiti minimi is of normal configuration, whereas on stimulation at 29 centimeters proximal to the wrist, the action potential in the abductor digiti minimi is abnormal. So, the last area where the amplitude was partially maintained before the 63% amplitude drop occurred 29 centimeters proximal to the wrist or 6 centimeters below the elbow. So this gives us the inference that the maximum area of focal demyelination occurs just proximal to that point at around 5 centimeters below the elbow. There is also the role of electroneurometry in the intraoperative period, mainly for diagnosing the actual site of compression in cubital tunnel syndrome. This can be done by a minimal incision made over the region of the cubital tunnel and the nerve action potentials recorded. The dilemma is whether the compression is in either the region of the ulnar nerve below the humero-ulnar arcade or in the region of the retroepicondylar groove. If the intraoperative nerve recording shows focal slowing at the level of the humero-ulnar arcade, all it needs is a simple release of this structure, which can be done immediately. Or if there is an involvement at the level of the retroepicondylar groove, it needs either anterior transposition or medial epicondylectomy. I hope you enjoyed the video. I enjoyed making it. Kindly click on the shown links to see more about the ulnar nerve anatomy and the clinical examination of a patient with an ulnar nerve palsy. And do not forget to subscribe to keep connected with the latest in learning hand surgery.